All right, so it's the Cardiology Grand Round Times. Good evening and welcome to today's Grand Rounds. It's again a very interesting and innovative Grand Round talk, one of the series in which we are examining the future of cardiology, how it's going to evolve. And one of the contributions to this field has been the area of digital health. Today, we're going to actually see how the landscape of clinical cardiology and the upcoming digital health technologies and telemedicine and so on and so forth have created an intersection of what is called as integrative cardiology. And this field of integrative cardiology is an area of great heightened interest currently. And before we get through into the presentations and the speakers, I'm going to do my part to make sure that we have our CME and MOC components taken care of. So as you know that we have our Cardiology Grand Rounds being stored on the website where you can just go there, log on and hear them anytime you want. And for the CME credits for this session, please go ahead and text 12449 to 888-816-4893 as an SMS message, which you can do within 12 hours after the session is over. And your mobile number from where you're texting should match the mobile number which is actively in record in the Rutgers Cloud CME platform. We also know that we provide MOC credits to our physician colleagues. And for that, you will have to go through the same steps. So do the CME. And after you have done the CME component, go to this particular website. And at the website, you will have a room code future07. We'll provide all of these details in the chat box during the sessions. You'll have future07, and you would have to answer the questions at the conclusion of the presentation. If you answer that correctly, then your MOC credits will go and get registered with your ABIM. Of course, it requires that you have registered with your date of birth and ABIM ID in the Cloud CME profile. All right, so with that, it's my privilege and honor to once again welcome back Dr. Regina Drews, who's the speaker for our session today. Dr. Drews was there in the first few sessions where we introduced the concept of future of cardiology on digital health as a discussant. Today is going to give her presentation on success and failure, heart failure, and provide some insights into what she practices as we call as integrative cardiology. Dr. Drews is a very accomplished name in digital health. Particularly, I met her during the ACC Innovation Meets. She was the chair of the National Physician Leadership ACC Innovation Healthcare section for 3 years, 2017 to 2020, and currently also is the Leadership Council Strategy holder for the ACC Digital Strategy Committee and involved in some of the ACC forthcoming vision in this entire area. Dr. Drews is founder and medical director of Integrative Cardiology Service Line at St. Francis Hospital. And she's also the National Director of Cardiology, ChenMed, where she has addressed heart failure, atrial fibrillation using some digital and data AI techniques, digital health and AI techniques. So I'm really intrigued what it's going to be today in store for us. And besides that, she has a prolific career, and most importantly, she's so easily approachable. It's a one phone call away, and she's always ready to provide information about so many of the strategies that the ACC is coming up with. So Regina, welcome back.
Partha, thank you very much. I really appreciate the invitation and the opportunity. I have a lot of excitement for integrative cardiology, and it's truly an honor to be able to share this concept with your colleagues. And I'm hoping that some of them, maybe all of them, will decide to embrace it and, take it upon themselves to bring it to your institution. But I think there is a lot of opportunity right now for cardiologists to really bring together the digital
Awesome.
health, the artificial intelligence, and merge it with our clinical practice. So do you want me to go ahead and get started?
Yes, and I just wanted to quickly introduce also our discussant for the session, Dr. Danielle Moyne. And the reason Dr. Moyne is an automatic choice to be a discussant is because he was the mentor for a group of fellows who won a digital innovation project recently. And I thought it was a good idea for us to bring in a heart failure specialist. So Dr. Moyne is an assistant professor at Rutgers Robert Wood Johnson Medical School, and he's extremely well trained in advanced heart failure. He was trained at Mass General Hospital. And subsequently after that, he was for a short period of time at Stony Brook as a faculty. And then we are really delighted he has joined us, and he's creating, I think his interest is in pulmonary hypertension, but I think in general, he's very open to innovative methods. So we'll see how much this could be a carryover to an advanced specialist like Dr. Moyne. So Regina, the floor is yours.
All right. Well, it's interesting that Dr. Moyne and I, we actually used to belong to the same institution, but we didn't really overlap. So, I'll be very curious, Daniel, to hear your comments later on. So I'm inviting you today to journey from heart failure to success by focusing on energetic milieu of the myocardium and energy as a concept in the heart failure management. I don't have any disclosures of relevant financial interests. And the agenda for us today is to expand and understand the core principles of what is actually integrative cardiovascular medicine, explore myocardial energetics and its role in normal function as well as disease states, and zoom in on pharmacological and non-pharmacological interventions such as lifestyle, including nutritional manipulations through ketogenic diet and targeted supplementation as adjunctive treatments for altering myocardial energetics in heart failure. So my career path, as Partha mentioned, is sort of been in multiple places, and I find Sheryl Sandberg's book, Lean In, Women Work, and the Will to Lead, sort of representative of the jungle gym. I emerged initially after my fellowship as a typical non-invasive cardiologist, actually cardiac imager with an interest in echo and nuclear cardiology and subsequently cardiac CT. And somewhere along that path, really developed a lot of interest in digital health tools, leveraged those into solo private practice, and then returned into a hospital fold as a chief of cardiology while revamping my practice model into a hybrid approach. I actually exited private practice by merging it with San Francisco Hospital, and that happened as I was seeking further training in business and organizational leadership, and that led me to my current roles, which is Director of Integrative Cardiology, as well as National Director of Cardiology for a private Medicare Advantage physician group. So what is integrative medicine? Hopefully your definition of integrative medicine is not getting vitamin C from coffee and vitamin D from donuts or vitamin B from bagels, but a more refined definition that recognizes that we have an opportunity to incorporate certain techniques such as acupuncture, herbal techniques, nutritional lifestyle, with a systems biology approach, something that had been popularized by naturopathic physicians and leveraged into the field of functional medicine with what is known as complementary or alternative medicine, and that might be, for example, massage or chiropractic manipulation, as well as what we usually excel in as cardiologists, which is conventional medicine of procedures, interventions, emergency services, and medications.
Dr. Drew,
And so
if I may interject, do you want to share your slides, please?
Oh, did I not? I apologize. I may not have done that. You see, even with the best practice, one doesn't always get everything done. My apologies. Okay, can you guys see it now?
Yes.
Yes, excellent. So this is where we were. And so let me just go one back. So those were the vitamins, the healthy snacks at work, C and D and B. And we were actually at the first question, and you can type your responses into the chat, although I cannot see the chat box. But hopefully I can hear from the moderators where most of our audience is getting this right. Do we think that social determinants of health are part of the integrative medicine domain? Is it true or is it false? So I'll give people maybe a couple of seconds or so that we can actually get some of these responses. And just Partho, or I guess whoever is moderating, can you please shout it out? Are the people putting it in the chat box? Because somehow I cannot see that in my display. So hopefully most people say that it is true. And indeed it is true, because contemporary integrative medicine is actually about the fusion of conventional and complementary approach, focusing on holistic and patient-centered care. And it includes a lot of mental, emotional, functional, spiritual, social, and even community aspects. And at the center of these circles is actually a person, a patient that we're trying to serve. And the focus of integrative medicine expands beyond organs-driven organ systems and really focuses on an individual, promoting well-coordinated care, including the social determinants of health. You may be surprised to find out that the spending, complementary health spending out of pocket by patients in this country in 2012 actually reached slightly over $30 billion. For comparative purposes, the spending on congestive heart failure in the same time period was $30.7 billion. So they're about $500 million apart, but you could see that overall is very comparable numbers, considering that the complementary approaches are actually out of pocket, and the heart failure spending primarily is part of the conventional insurance-based care. One starts to wonder, what are the reasons that we actually seeing this? And we're seeing this because healthcare is becoming more consumer-oriented and on demand. There is significant expansion in direct-to-consumer genetic sequencing, wearables, trackers, as Partha alluded to earlier, and emergence of biomarkers and quantified self as a concept. Of course, it's also coupled with e-commerce and what is called the paradox of health, a situation where acute infectious diseases and trauma have been largely dealt with, of course, notwithstanding the most recent pandemic, where patients are much more focused on the chronic diseases that unfortunately do not go away. And so in terms of what we actually hope to accomplish, if we do believe that integrative medicine is good for us, I'm not sure why it's trying to advance itself, but never mind. We really would expect, the integrative medicine to be like Starbucks, right? Present on every corner. But the problem is that it's a discontinuous innovation, and patients very often see integrative medicine as a parallel track and not something that is going to mesh with their standard physician type of care. And so hopefully I can convince you that the contemporary integrative medicine is not like that. So in my practice, the pattern that emerged was actually high touch and high digital tech practice, where proprietary protocols are used in addition to outcomes based on genetics, nutrition, lifestyle, and biomarkers, as well as telemedicine and various secure communication and digital therapeutic resources. And the practice model is a hybrid model that gets referrals from traditional practitioners as well as complementary practitioners and patients themselves, and allows for multiple revenue streams. So how does it actually work? So my focus today, even though I'm not a heart failure doctor, I work with a lot of heart failure doctors and I get referrals from them. My focus is on myocardial energetics in health and disease. And for that, we're going to meet Dick and Jane. Now, my patient case vignettes, representative of the real patients, of course, their names have been changed, and I like that movie quite a bit, Fun with Dick and Jane. If you hadn't watched it, please do. It's pretty funny, but it actually has a very important message. And so Jane, she's 94 years old. She had paroxysmal atrial fibrillation since 2017. I met her earlier in 2021. In 2019, she was admitted for pneumonia, and no one seemed to have noticed that during that admission, she sustained a quite significant drop in her ejection fraction as compared to baseline studies in 2017. Despite that, she wasn't really in guideline-directed medical therapy. Jane is a very active 94-year-old. She goes on daily walks, she does yoga and stretching, she's absolutely cognitively intact, and she lives by herself. And what was notable about the 2021 is that her chest x-ray, even on discharge, still showed some congestion. She went home on oxygen that she used overnight, and her most bothersome symptoms, of course, was fatigue and very significant loss of function. And so I was contacted by her son, who provided me with a copy of articles from Jack. And that, by the way, how integrative practice runs. We have patients that have a lot of very intense and sophisticated exposure to the internet and literature, and his request was for me to put this patient on the ketogenic diet. Now, before you're going to say this is all nonsense, just give her GDMT and call it a day, I'm going to ask you to reserve your judgment and let us move forward. Now, Dick, of course, is a bit different. He's younger. He's 63 years old. When I met him, he worked as a teacher. Unfortunately, the school where he worked was pretty far away from his home. So he was driving 3 hours each way just to get to work. Needless to say, he had no time for exercise or diet. His level of stress was very high. And because of that, when he would come home, he sort of had a nightcap, sometimes 2 or 3, and eventually presented to a cardiology colleague of mine with fatigue and shortness of breath, and was found to have ejection fraction of 30%. They appropriately sent him for an angiogram that showed clean coronary arteries, but confirmed the ejection fraction. And so he was advised that he has new onset cardiomyopathy, and was appropriately advised to be started on guideline-directed medical therapy, at which point he rebelled and said that the cardiologist just gave him a book on plant-based diet and said that despite all of it, he has to use medications. And so he presented in my office with a bag of dietary supplements, reporting chronic antibiotic suppression, and he was significantly overweight. So let's talk about what actually unites both of these patients. And Dr. Moen probably knows this much better than I do, but we have come to realize that the issues with heart failure go beyond just the pump function and truly reveal to us that the energy, the metabolism of the myocardium is a critical variable. Now, we know from basic biochemistry that utilization of glucose versus fatty acids is very different in terms of energy generation as measured by the ATP. For each millimole of glucose, one produces 30 molecules of ATP, while the same mole of fatty acids actually gives us significantly more, 134 moles of ATP. Now, why is it important? It's important because when our body utilizes fatty acids, it actually produces something called ketone bodies. And you see them here in this diagram represented as acetoacetate and beta hydroxybutyrate. And those ketone bodies essentially power up the mitochondria and power up the TCA cycle to produce tons of ATP, as I showed you in the previous slide. So as you could imagine, the energy-intense organs, brain, heart, and even skeletal muscle, love this increased energy supply. And the myocardium itself is a very interesting organ. It's not comparable necessarily to the, for example, skeletal muscle that we have in the human forearm. In the skeletal muscle, if, for example, insulin levels rise, you could see that ketone bodies, here they are in this dark maroon color, abbreviated as beta hydroxybutyrate. These ketone bodies continue to be utilized at nearly constant level as insulin induces net release of lactate and a change in metabolism. Now, in the heart muscle, myocardium is what's called a thrifty substrate, meaning that when insulin levels are high, myocardial metabolism actually changes to pyruvate lactate and glucose and stops energy generation or diminishes energy generation from the free fatty acids as well as the ketone bodies. So why is that important? It's important because that essentially deprives myocardium in the setting of insulin resistance from the ability to generate energy substrates that are needed for normal function. And so as insulin to glucagon ratio falls, that means an individual is insulin sensitive, myocardium metabolism will include fatty acids and most importantly ketone bodies. But if insulin to glucagon ratio rises, myocardium essentially manifests what we typically call insulin resistance and change to glucose metabolism, thereby reducing the energy output available for function. And so some of the people investigating this came to realize that there are therapies available to us, mostly lifestyle therapies, that potentially could bypass this situation of insulin resistance of the myocardial tissue and actually augment ATP production and, of course, increase the oxygen efficiency and through additional mechanisms reduce oxidative stress and inflammation. And an interesting conceptualization of this actually was recently published in JACC, where the article focused on bioenergetic and pleiotropic effects of ketone bodies, what liver actually generates from fatty acid metabolism. And it was observed that not only do ketone bodies improve mitochondrial function and improve cardiac energetics, but they seem to positively affect blood glucose and lipid profiles, contribute to weight loss, relax the endothelium, resulting in improved renal perfusion and improvements in blood pressure, decrease oxidative stress and inflammatory markers, positively affect cardiac remodeling, and even influence histone acetylation, which is one of the ways that DNA expression is actually controlled. Moreover, we can certainly deliver some of these ketone bodies exogenously. Now, they're not always very pleasant because they either have bitter taste or potentially result in gastrointestinal distress. And anyone who inadvertently tried too much bulletproof coffee actually knows this. I did that and I wasn't very happy. It contains MCT, as well as through the infusional route. And we can try to manipulate myocardial energetics exogenously, either through oral or intravenous opportunities to switch the body, even though temporarily, into ketosis. And this was actually done fairly recently, where in patients with heart failure and reduced ejection fraction, investigators tried infusion of ketone bodies and showed a fairly significant improvement in cardiac output, 40% from baseline, with an 8% absolute improvement in left ventricular ejection fraction. And so these hemodynamic effects of ketone bodies were dose dependent, and they were detectable in physiologic concentration ranges.
And the hemodynamic effects of these infusions were apparent in both patients with heart failure and reduced ejection fraction, as well as in patients who are age-matched controls, with investigators purporting to say that this study demonstrates how modulation of circulating ketone levels may actually represent a novel infusion therapy in patients with heart failure. So if that sounds familiar, it probably should, because recently we had a new class of medications that have emerged as probably the most potent medications for heart failure. And I don't know if Dr. Moen will agree with me, but I feel that those medications will likely replace Entresto, sacubitril valsartan, as a class 1 indicated medications, just because of the sheer magnitude of their impact across the range of ejection fractions, as well as preservation of renal functions. But SGLT2 inhibitors have been shown to improve significantly on a lot of heart failure outcomes. How do they actually work for modulation of heart failure? Well, SGLT2 inhibitors potentially work by promoting ketone consumption by the myocardium. And so this slide should kind of look familiar by now, because we looked at some of these pathways in the earlier slides, and you could see how one can modulate these pathways through lifestyle intervention as well as through medical interventions. And indeed, this had reignited an interest in ketosis on the part of cardiovascular practitioners, with available options that include oral ketone solutions, which so far had been studied in healthy participants, such as athletes, with documentation of improvement in circulating free fatty acid ratios and improvement in exercise distance, muscular glycogen content, and glycemic control. Intravenous ketone salt infusions, which of course are maybe difficult in heart failure patients because of sodium load, as I showed you previously, have shown promise because they augment cardiac output and they are decongestive, as well as provide some potential opportunities in regulation of myocardial blood flow and reduction of oxidative stress. And of course, SGLT2 inhibitors that we now know promote a degree of endogenous ketosis on the tissue level. Now, this slide, believe it or not, is slightly out of date, because while the medications work through that mechanism, in addition to glucosuria in diabetic patients, they have been shown to be very effective in heart failure patients, regardless of the presence or absence of diabetes. And so the story of SGLT2 inhibitors is very diverse, as they consistently march through a range of validation studies, showing very convincingly that for heart failure with reduced ejection fraction, those were the earliest studies, the drugs powerfully reduced unplanned hospitalization or urgent care visits, as well as cardiovascular death. And so hopefully you have listened, to what I said just maybe a minute ago, and I know it's late in the afternoon, so I want for everyone to think, what do they know today about SGLT2 inhibitors? Do they reduce just cardiac mortality, CHF hospitalizations, or urgent visits for congestive heart failure? I'll give you a chance to think about. And hopefully you will agree with me that maybe based on the studies that came across in other presentations or through your review of medical literatures, that we can make the case that as a class, these medications actually reduce all of the above. And so the pivotal studies were in heart failure with reduced ejection fraction. Both leading agents have shown very similar results of reduction in cardiovascular death, as well as heart failure endpoints. And we know now, most recently from the meta-analyses, that the effect of these medications that again promote ketosis of the myocardium actually spans not just reduction in cardiovascular death and hospitalization, but also favorably affects progression of chronic kidney disease. Very, very recently, in August of this year, the findings were extended into patient populations that have heart failure with preserved ejection fraction or moderately reduced ejection fraction. And I believe just yesterday at the American Heart Association, the results of Emperor Preserved were presented yet again, showing early and sustained improvement among patients with heart failure with preserved EF, including those where ejection fractions were 50% or more for all cause and cardiovascular mortality, hospitalization, quality of life, as well as reduction in new onset of diabetes mellitus and renal endpoints. So why am I telling you this? I'm telling you this because integrative approach to re-energizing the myocardium has to count in the most recent benefits from the new drug classes, as well as lifestyle interventions that are directionally aligned with the benefit of generating ketosis in the myocardium itself, or putting the heart into ketosis, not necessarily the patient, but putting the heart into ketosis. And so a question that occurred to me, if I had a stable CHF patient and they were only willing to tolerate one medication on this list, based on their mortality reduction data, what would you prescribe and what would I prescribe? The conventional guidelines right now will probably pick an ARNI, which is Entresto. But based on the recent data, I do believe that we're probably going to see an emergence of these SGLT2 inhibitors to the top spot. They're already part of the so-called quadruple therapy for congestive heart failure with a beta blocker, ARNI, mineralocorticoid antagonist, but I believe that based on their utility and the fact that they don't have significant hemodynamic side effects, as well as could be applicable to patients across a range of ejection fractions and protective of the kidneys, we may actually see a displacement of ARNI with the rise of SGLT2 inhibitors to the top spot. However, whether it happens or not, the quadruple therapy in and of itself is very powerful, and achieving the cumulative risk reduction if the therapy is used appropriately, that only requires approximately 4 patients to be treated. And this is a very impressive outcome with 2 of the agents on this list really being developed and validated in the past few years. And as been seen with sacubitril valsartan across the range of ejection fractions, we're seeing the benefit in patients even at EFs which are in the less reduced range or mildly reduced range, typically 41 to 49%. And we're certainly seeing it right now with SGLT2 inhibitors in patients whose EF are 50 or greater. And so while the benefits of Entresto and ARNI, and it continues to be in the #1 spot for guideline-directed medical therapy, are apparent, the benefits are most clearly identified in patients with reduced ejection fractions. However, what should we do with regard to actually promoting the benefits of myocardial ketosis? Can we create strategies that will supplement, augment, and sometimes potentially substitute for certain medical therapies if a patient is concerned about them, cannot afford them, or cannot tolerate them? And that brings us into consideration of metabolic adaptations that go into various ways of inducing myocardial ketosis. This particular article in the New England Journal of Medicine really looked at the metabolic adaptations that are related to intermittent fasting. And this is an important teaching point, sort of a pearl. Most physicians and patients identify ketosis as an excessive or more than 60% macronutrient utilization of fat. However, one can actually produce mild ketosis without altering significant macronutrient distribution and have a much more typical distribution of macronutrients, but using intermittent fasting and time-restricted eating. And this approach actually has been shown to have a variety of benefits, including improvement in stress resistance, significant improvements on the level of using ATP production, with improvements in mitochondrial biogenesis and something called autophagy, which is actually resolution of old and senescent cells and sort of clearance of the cellular debris. And what, of course, is close to my heart, no pun intended, is the fact that this effect is manipulated by intestinal microbiota, sort of the holy grail of integrative medicine. And it's more of a systemic effect, right? So we're talking about systems biology approach, because it affects our heart, our muscles, our brain, our genetic expressions, our mitochondrial expressions, the engagement of our inflammatory pathways, such as mTOR, and even something called BDNF signaling. BDNF stands for brain-derived neurotrophic factor, a very important growth factor for patients, especially as they get older, because it functions in maintaining the health of our central nervous system. And so intermittent fasting flips on a metabolic switch. The periods of intermittent fasting lead to systemic and cellular adaptation. And here come our old bodies, right? Increased ketones. And then, of course, there are periods of recovery when the body reconstitutes itself. And this is called metabolic switching, a metabolic flexibility. And for example, many of our patients actually lose metabolic flexibility. Now, Dr. Moyne will probably tell you that many of the heart failure states, especially advanced heart failure states, are characterized by fairly high insulin resistance. And so that ability to switch metabolism becomes impaired in our heart failure patients as they progress down the path of that very complicated syndrome. Now, long-term adaptations of intermittent fasting are actually favorable. They're more favorable than having somebody on a ketogenic diet, because ketogenic diet in and of itself actually does not lead to a healthy gut microbiome. Very often leads to an impairment in gastrointestinal microbiome, while intermittent fasting preserves healthy gut microbiota and certainly increases disease resistance, as well as increases insulin sensitivity, reduces inflammation, and leads to favorable changes in terms of reduction of visceral adiposity. So which diet is known to reduce both total and cardiovascular mortality? I don't know if I need to give you the answer now, or you want to think about it a little bit. Partha, do you want to let me know? Am I supposed to give out the answer, or do we have to let people guess?
No, I think it's fine, because you can lead them. That's not a problem.
All right, I will lead them. Well, think about a diet that was actually observed in real human populations on a very large scale, and probably have been there long before we entered, different dimensions with all other different diets. And that, of course, undoubtedly will be Mediterranean diet. So let's come back to our Jane and Dick, so that we can actually figure out what are we supposed to do for them. So for Jane, I communicated with her cardiologist, and he agreed that starting low dose Entresto might be helpful, although unfortunately she became hypotensive with the medication, and she couldn't tolerate beta blockers because she was bradycardic. From the integrative cardiology perspective, I asked her to allow herself 20 minutes outside in a daylight for circadian rhythm synchronization, and I put her on a low glycemic index diet combined with time-restricted eating, which essentially is a variant of intermittent fasting. As I showed you just a few slides ago, this is enough to initiate mild ketosis without giving a patient excessive fat consumption in terms of micronutrients. I had augmented her protein intake using plant protein for breakfast and added a variety of dietary supplements, mostly multivitamin, multimineral as they're called, as well as CoQ10 some insulin sensitizers, which are bergamot and amla. These are those herbal compounds or plant-based compounds. Added curcumin and glutathione, which are antioxidants, as well as digestive enzymes because of increased plant protein use, and zinc for just tissue stabilization. And so the good part is that she had a tremendously robust positive response. She was able to come off her home oxygen. She was able to resume basic stretching. And the most important time, I guess, a win, was when she felt well enough to be able to come for an in-person exam, because prior to that we did telemedicine. And I'm happy to report that it's now been about 6 months and she has not had any additional hospitalizations, and she is doing very well, and will be turning 95 in early 2022. Dick, also very similar intervention. I actually put him on the medications that his cardiologist advised. I encourage him to use those and titrate those to tolerance. This was probably the most aggressive integrative cardiology intervention was number 2, convincing him to rent a studio by his work so that he's not commuting for 6 hours per day, which he actually did, and he felt much happier about this. He also re-engaged with his therapist to stop using alcohol recreationally. Now, his approach was low glycemic diet combined with something called fasting mimicking diet. I'll be able to answer your question if you have a question on that, what it actually is. And he began to incorporate resistance and aerobic exercise into the hours that he now had free, since he wasn't commuting for 6 hours per day. He also engaged in mindfulness and heart coherence work, as well as baseline supplement recommendations and very minimal hormonal optimization without any bioidentical hormonal treatments. And the outcome was fantastic. He lost 27 pounds. His orthopedic surgeon was pleased with his progress, so he actually stopped chronic antibiotics that were kind of essentially annihilating his microbiome, and he was on these for the past 10 years or so. I have known him for approximately 3 years, and he had sustained recovery of his ejection fraction. It's been at 55 to 60% range for the past year or so, maybe a little bit more. So I'm very encouraged that he will actually maintain this. I did not stop his GDMT. I essentially have him in exact same doses that we titrated to, because as you may know, the literature sort of reflects that if these medications are stopped, some of the patients kind of slip back into this mildly reduced range potentially. So, you know, good win and a happy patient, and hopefully these cases, in conjunction with the preceding discussion, have given you a flavor what integrative cardiology is really all about. I didn't present here the biometric data. Both of these patients were actually collecting the biometric data. My 94-year-old patient is guided by her sons, and she is actually using a ring that samples her oxygen saturation. That's how we know exactly what happens with her oxygen saturation. And Dick here is using continuous glucose monitor, as well as the Apple Watch for some of the biometric data. Actually, Jane, 94-year-old, also uses an Oura ring to see her heart rate variability and her sleep stages. So I sort of kept those out of the discussion because, you know, this could take hours in and of itself to discuss various variables. But I think the flavor and the opportunity should right now be obvious to you that you can truly personalized management of a patient with cardiovascular disease, especially a patient with congestive heart failure, where prognosis typically is not great, by giving this patient confidence and leadership in being able to advance their guideline-directed medical therapy, as well as incorporation of these lifestyle interventions that are based on myocardial energetics and what we're learning about system biology approach to really provide this holistic 360-degree opportunity for these patients to get better. Thank you for your attention. I'm going to stop sharing so I can actually see everybody at this point. All right.
All right. So, Regina, so wonderful. And, you know, we listen about all kinds of talks, devices, and all kind of classic cardiology talks. And this was really a great change because you emphasized something that we really don't think about, and it really made me think a lot. I have so many questions, but I want to make sure that I start asking the things that are coming on the chat box. So one question that came on the chat box is, how does inflammation and oxidative stress response in the body affect the TCA cycle and in turn the myocardial metabolism? Is there a role for oxidized cardiolipin in this pathway? And I don't know all of that, but maybe you can answer this question.
So inflammation and oxidative stress actually over time poison the mitochondria, right? And they decrease the ability of the TCA cycle to generate ATP. I'm not aware of any specific interventions that are using oxidized cardiolipin. I'm not quite sure what that is. I think the measurement of oxidative stress is actually available through commercial labs. One of the oxidative markers that one can use is actually oxidized LDL, right? You know, we typically see that patients who have very high LDL-C potentially have increased small dense LDL as well as oxidized LDL. Well, that's not always the case because patients may have elevated oxidized LDL without necessarily huge elevations in LDL-C. Additional measurement that is available also commercially is actually a degree of hydroxylation. There's something called 8-hydroxy manipulation of the DNA, which is also measurable. And that also is a marker of oxidative stress. In the absence of these, I think a practitioner could take a readily available measurement, which is high sensitivity C-reactive protein, right? Anytime we have hsCRP greater than 2, we should get worried. And even for patients between 1 and 2, they're sort of in that intermediate inflammatory range, because ideally, if a person is optimized, you would really be seeing their high sensitivity C-reactive protein definitely less than 1, maybe like 0.1 or 0.2. So, you know, the kind of triad of integrative cardiovascular medicine is focused on inflammation, oxidative stress, and vascular as well as systemic autoimmune response, right? And there's a wonderful body of work by Peter Libby and his group from Brigham that had shown beautifully how even something as a perception of stress that occurs in post-myocardial infarction patients actually induces immune response and mobilization of the immune system on the level of bone marrow and spleen to go and potentially heal the areas of a problem, such as, you know, area in the blood vessels that was recently manipulated or involved in plaque fracture or plaque erosion. And so there's a systemic link between stress exposures and how that actually translates into biological inflammation and vice versa, right? So very interesting area of medicine, including integrative medicine, lots of questions and suppositions.
Lots of questions, and you have really triggered me off because I never thought about this field and I'm really excited. So I'm going to ask now, Daniel. So conventional, and I mean, this is about my fellowship long back when I learned. So I learned that when you have an end-stage heart failure patient, they typically are in a state of catabolic milieu. And I would see when I was you in fact there's a reverse epidemiology. All the risk factors somehow get protective. So if a person is not eating well, and you in fact recommend a very high calorie diet and nutrition and all that before you put that patient through the transplant program and all. Now, coming back to what Regina presented, do you think we are probably boxing all of these patients into one area? Because maybe there are some people who are different. Maybe there are some other people who are different, and we really don't know their phenotypes. And I mean, it's just amazing. What do you think?
Yeah, Dr. Sengupta, I 100% agree. First of all, Dr. Drews, that was an incredibly enlightening talk. I think it kind of highlights our deficiencies as even heart failure specialists and how poorly we understand what truly drives disease. But what Partha says, I completely agree with. You know, when people get discharged from the hospital, we say 2-liter fluid restriction, 2,000 milligrams of sodium, and say, that's it. And I think that unfortunately oversimplifies the complexity of what's going on in heart failure. And I think, you know, after today's talk, for sure, I have a lot of work to do on my end. But yes, this is not a one-size-fits-all disease. And I think phenotyping even 2 HFpEF patients or 2 LV dysfunction patients is impossible to say that they're equivalent. And obviously, as we learn more and more about HFpEF in particular, there is a lot of work to do to understand how better to treat this disease. And it was funny with Dr. Drews talking about this 94-year-old lady. This is like my typical St. Francis patient. I missed them. But there's, you know, treating them is not, you know, as the case demonstrated, giving them Entresto, beta blockers, they may not tolerate those medicines very well, in which case the interventions that Dr. Drews spoke about become even more important. So I think it's incumbent on us to understand this disease, not just from the medicine standpoint, but from the integrative approach that was brought up.
So I'm going to come back to Regina. One question. So you mentioned about the mind-heart connection, right? So we really don't understand, right? And in between these all the inflammatory axes and what all is happening, who knows? You have syndromes that start with Takotsubo cardiomyopathy to extreme inflammation, and we definitely know the subarachnoid hemorrhage. There is a definite connection. We really do not understand. But one thing which I wanted to ask you is, if you were to physiologically monitor somebody's signals, let's say, I know that you use digital health tools, is there a surrogate of when I would call I'm inflamed?
100%. So I love patients who are like to use Oura Ring. I have no relationship to the company. I'm a customer myself. And the reason why I like it is that there is such a great opportunity non-invasively to obtain heart rate variability and to notice, you know, obviously if a patient has a device, one may be able to get heart rate variability from the device. But if a patient doesn't have a device, you know, how do you measure HRV? So the HRV varies tremendously depending on what I would call loading conditions, right? So in integrative medicine, we talk a lot about allostatic load, right? You know, imagine those experiments we used to do with frog muscle tied to a spring, right? You load the spring too much and the muscle is no longer able to contract. So this allostatic load varies from person to person, from day to day. And HRV is a great guide because you can literally help patients identify what are the triggers that are depressing their HRV, especially in heart failure patients. It's also a great marker of potentially increased inflammation. I think Oura as a company, I believe they still have a study with UCSF on detection of COVID using the basal temperature measurement as well as HRV. I can't recall if they published the results. I certainly haven't seen these, but I think there is a lot of opportunity in this non-invasive lifestyle monitoring that will sort of bleed into these options for us to personalize the facets of cardiovascular patient management. My personal favorite is actually a device that is produced by a company called HeartMath, right? It's a device that measures so-called heart coherence. It came from psychology and psychiatry, and then went a little bit more into disease states. And again, this is a little bit of a different measurement of HRV, but it's still within that HRV space. And actually, patients can get this device directly. It doesn't require a prescription. If they go on heartmath.com, I advise all physicians here to get it so that they can investigate on themselves and understand what actually makes them stressed, and use the device as an intervention to de-stress. So it's not just a diagnostic; it's also an interventional device.
So this is very exciting, because I think you're going to be my permanent guest. Because what you do is you make me think differently about everything. So this is brilliant. So heart rate variability, something that I think in my electrophysiology group, we have a fantastic crew here who can investigate. And I think with the availability of all this digital health tools, so you're making a point that by looking at the HRV and the dampening of the HRV. So a resilient system is one with the more variability, right? And the more fixed you are in a bad spot. So if you're more inflamed, then you're probably going to reduce your heart rate variability. And that could be an easy surrogate to identify that you're not in a fit state, that physiologically you're not at a good point. I would actually suggest, many times today, I had my COVID booster shot yesterday and I was achy the whole day. So I wasn't really not achy. I was not feeling well. Sometimes patients come, I don't feel good.
Right.
And, there is no clear bucket. It is not shortness of breath. It is not chest pain. Who knows? Maybe we need to give more quantitative directions to these states that they come up with, and digital tools provide us an alternative. And maybe we need to do many studies like that. So this is brilliant.
Yeah.
So I'm very, now I'm also excited about you put your patients fast, make them fast. Now, let me ask you a very straightforward question. It's not easy to fast. In Indian, in literature, in culture, we fast sometimes. And I wonder whether those ancient traditions were one of the reasons why people did that. I don't know. But fasting is not easy. Do people who fast, could that be, besides their surrogate of their ketogenic milieu that they can create, is a marker of their discipline? And because, I'm not sure, what's your percentage of patients that you advise fasting will really end up doing it?
I have to tell you, it depends on how you advise fast. Because intermittent fasting under most circumstances can be done even by patients who are older and sicker. Like, for example, my 94-year-old patient, she was able to do intermittent fasting for 12 hours. It wasn't a problem. So there are certain tricks. First of all, you have to make sure that majority of that fasting happens overnight when people are asleep, right? So it's sort of natural. And you synchronize it to their circadian clock. So this is a very time restricted eating. I find, and then you have to look and say, well, if my patient is employed, if my patient is involved with their family, how can I make it so that it becomes part of their lifestyle, right? They're not going to be perfect every single time, but if they're there 70% of the time, that's under their control, it's still going to have the benefit. So, for her, it was 12-hour intermittent fasting plus removal of what we typically know is inflammatory food, cookies, crackers, pasta, right? So high carbs that actually induce, they're not just bad sources of energy, they're much worse than that because they induced inflammatory response, right? And this is somebody with heart failure with reduced ejection fraction who is not very tolerant of GDMT, and additional inflammatory response on top of it is highly undesirable. So, so incremental steps, food substitution, understanding your patient lifestyle, the barriers that they have, helping them to see it as a journey and not an end goal, right? I can't go there and say, you're going to fast for 12 hours and that's it. No, I have to say that let's work at it together and we'll figure out what works for you and what, might be the barriers that we have to figure out how to overcome. And so, that degree of personalization, I think, is important if we want to see our patients, succeed. And just as you said, when I got my booster, I had a terrible reaction, and my Oura ring was basically lit up red like a Christmas tree. I have never seen an HRV that low in my entire time of monitoring myself. So there is a lot, to it.
So, Daniel, based upon this, what are you going to do tomorrow to your heart failure rounds? What are the modifications that you're going to do?
I think practically, they're just spending an extra couple of minutes talking to patients about, what Dr. Drews brought up. I think we do, as I mentioned, a really rotten job of understanding that aspect of the disease, which I think needs to be highlighted more. And I think the data, particularly with SGLT2 inhibitors, because there's always been this debate about why do they make cardiovascular outcomes better, right? What's the missing link? And if ketosis is the missing link, we need to hone in on that and make sure we're doing a better job of addressing that therapeutic pathway.
And maybe we need to do some studies to make sure that we can detect those states using digital health tools. And lastly, before the night ends, I wanted to ask a burning question. What does alcohol do?
What does alcohol do?
Due to your ketosis state and
So this is one of the things patients who work with me have to give up, especially in the active phase. I ask all of them to stop alcohol consumption, because I had seen that, remember that alcohol has a direct toxic myodepressor effect, right? It happens, we are conditioned to think that somehow it happens at higher doses. We don't know what actually is the threshold dose for any individual patient. And the problem is more pronounced in women than in men. It interferes with microbiome. It slows gut transit. It disrupts, hypothalamic pituitary adrenal axis. So I do request that they stop. So for the 3 months usually that they work with me, they stop or substantially decrease. I let them use caffeine, because if I had them stop coffee, I would just have like a massive riot. So, so that is not happening, but, they have to cease alcohol consumption for the active phase of the program intervention.
Thank you very much. That was terrific. I really enjoyed this. This is a completely alternate landscape you took us to. And I look forward to trying to bug you with more hypotheses and let us get this journey straightened out. Thank you very much and good night.
Anytime. Thank you for having me. Good night, everybody.
Thank you, Danielle. Yeah, thanks.
Bye-bye.
Bye-bye.